Today I'm going to discuss about nutritional management of obesity for the next 15 to 20 minutes or so. So these are my learning objectives. I'll be talking about how to diagnose the obesity and what are the evidence-based intervention that we can do to reduce this obesity burden. And now, as you all know, this is obesity is in pandemic proportions, causing high metabolic risk and cardiovascular risk all across the countries and the worldwide. And also, there are a lot of causes for this obesity. And as general practitioners and medical officers, I think you will be able to play a crucial role in managing this obesity, as this needs some sort of a long-term follow-up and coordination. What is the prevalence of general and central obesity in Sri Lanka? It's this is around 2020. National adult data shows about 25% of adults are obese, and about 26% is having central obesity, and central province also having 32% overweight, 12% obesity, and central obesity is around 17%. Not only that, adolescent girls are also similarly affected, and hospital data also shows this more or less same data. How do we do this assessment? It usually involves anthropometric measurements and biochemical measurements like metabolic screen, and also we need to assess their lifestyle, like eating patterns, physical activity, and the medication history, and also as a new entity, if the patient is admitted with obesity and with other complications, there's a tool called Global Leadership Initiative Malnutrition Screen, which will be talked in the latter part of the lectures. So this is obesity is one aspect of the double burden disease, and as I explained, this is the prevalence is rising alarmingly, and now WHO has identified this as a disease, not the comorbidity, it's a disease, and defined as excessive accumulation of fat leading to impaired health. So how do we diagnose obesity? According to the BMI, as you all know, if the BMI is around 23 to 25, Sri Lankan cutoffs taken as overweight, and if it is more than 25, it is obese. But obese BMI is not that sensitive to detect the fat mass from the muscle mass. So clinically, what we can do is we have to measure the waist circumference. If it is also more, like more than 90 centimeters for the males, more than 80% for the females, we can clinically say if the BMI is also in high range, then we can clinically say patient is having visceral fat, high visceral fat, and also the generalized obesity. So both BMI and waist circumference are very important to diagnose this obesity correctly. So what is this visceral adiposity? As we all know, when there's energy excess, this fat called visceral fat is getting accumulated, especially in the abdominal, intra-abdominal organs, liver and the pancreas, and also the pericardium, and all the organs are getting affected. Because of that, they are producing a lot of inflammatory markers like TNF alpha and interleukins and all, leading to insulin resistance or the inflammation. So if we are to do a high sensitive CRP on this sort of patient with high waist circumference, it's going to be high. And also nowadays it's taken as a cardiovascular metabolic risk factor as the high sensitive CRP price. So this insulin resistance leads to secondary acanthosis nigricans, causing dark pigmentation around the neck, axilla, and groin, leading to metabolic complications like non-alcoholic fatty liver disease, polycystic ovarian syndrome. If the insulin resistance is in the ovary, it's polycystic ovarian syndrome. If in the liver, it's NAFLD. Likewise, obstructive sleep apnea, also very common in these days, and metabolic syndrome as a part and parcel of this central obesity and the metabolic diseases. Having said that, we have to exclude secondary causes as well if you are to diagnose the simple obesity or the lifestyle related obesity. So basically, we can do endocrine assessment if the features are there. Cushing syndrome, hypopituitarism, hypothyroidism, we can exclude. And if there are syndromes, especially in the pediatric population, causing this obesity, and also there are well-known drugs like olanzapine, like antipsychotics and steroids, sulfonylureas, and insulin, and also they can cause this visceral fat and the weight gain as a secondary cause. And if the patient has undergone hypothalamic surgery, tumors affecting satiety centers, of course they will develop abnormal satiety and the hunger, and that will lead to secondary obesity. Having excluded all this list, you can diagnose simple obesity. So having excluded secondary causes, we can diagnose simple obesity. And in this simple obesity, as you all know, lifestyle changes is the main cause. In that lifestyle change, dietary causes will be playing a major role. So what are the dietary causes? Like, as we all aware, high carbohydrate and starch intake like rice, cereal, starch, vegetable, sweets, foods, all increase the risk of simple obesity. And also high oil fat consumption and high sugar intake, sweets, beverages, and fruit juices, and all increase the energy. So basically that will increase the energy surplus in the body, leading to the simple obesity. And other poor dietary habits are also well known to cause this obesity, like skipping breakfast, leading to taking a heavy late dinner, and quick eating behavior, and sweeping method, like we are forced to clear the plate, and eating while watching TV, so we are distracted and so we don't know what we have eaten. And also having a nap after eating heavy meals, that will increase the fat deposition. And some of us are eating dessert just after main meal, that will increase the glycemic load, that will increase the visceral fat collection. And poor sleep hygiene, it's if you sleep less than 6 hours at a stretch, that can change the hormonal balances, leading to visceral obesity as well. So how can we treat this simple obesity? As we aware, the lifestyle modification is the main thing. Dietary changes and physical activity plays the main part of the obesity management. And pharmacotherapy, like medication, there are medications to treat obesity as well. And surgery, like bariatric surgeries, are also now very popular to treat this simple obesity. So lifestyle modification plays the main part, as I explained. So we have to reduce the weight by 10%. That is to reduce the cardiometabolic risk. So if you can achieve 10% weight loss from the baseline, that is ideal to reduce the CVD risk. But you don't have to go to your ideal body weight, and that need to be done like 3 to 6 month duration. And we need to measure their dietary and physical activity using the sophisticated methods, like now we have all the speedometers, accelerometers, and smart watches and all. And very importantly, we have to monitor and document the body weight and the waist circumference. And the dietary modification needs to be individualized. And so we have to have the agreement with the patient in order to implement the diet plan. And this shows the obesity plate method, plate model, where the half of the plate would be like non-starch vegetables, quarter would be cereals, and quarter would be protein. So this is a good point, but most of us are like eating the reverse of this plate, so it's better not to go for this plate at the like next day. You have to do it gradually and come to this plate. And intermittent fasting is well known and well practiced here and worldwide as well, but there are like, it's a time restricted eating, so there are different methods like according to the fasting time duration. Meta-analysis were showing like 4 kilogram initial weight loss compared to controls, but the problem is it's like very difficult to adhere in long term, so most of the guideline they don't recommend for long term weight loss. As a short term weight loss method we can use for this to reduce the insulin resistance and inflammation and hypoglycemia and diabetics as well. Ketogenic diets are also well popular, very much popular in these days. So where we prescribe less than 50 grams of carbohydrate per day with high amount of protein. And it has also shown to be effective to reduce the weight in short term, but not in long term because it's very difficult to follow and most of them are getting back to their usual dietary habits. And if we are talking about energy deficit diet, so when you reduce the starch component you will be feel more hungry, where you have to eat healthy snacks like yogurt and low or non-fat fresh milks, sugar-free jellies, and sour fruits. And likewise you can eat these sort of healthy snacks to suppress your hunger as a snack. And meal replacement are also well known to be used for to induce weight loss, which is having a very low amount of energy, high amount of protein and fiber to induce ketosis, and that will suppress the appetite to induce rapid weight loss. Behavior change, as we all know, it's very important. It's need to be individualized. So BMI more than 27-30, the cardio exercises like doing weight bearing exercises are not advisable to preserve their joints. And also best exercise would be swimming for those sort of patient, or else if the BMI is around 25, properly they can do the cardio weight bearing exercises depending on the circumstance. They need to do like 60 minutes walking to induce a weight loss per week, at least like 3 to 5 days per week. And they have to do resistant exercises like 10 to 15 minutes at least resistant exercises to preserve their muscle mass at least 2 times a week. And uh, behavior therapy, when we do this lifestyle modification, they usually get depressed because of their pleasure of eating is usually gone, so they can get depressed. So we have to be aware on that, and counseling and the psychiatric inputs will be important for these sort of patients. And operant reinforcement, that means when there's a positive thing, we have to give more sort of positive feedback for the patient to keep the patient on the track. And continuous follow-up is very important, but as you all aware, weight maintenance is very difficult because our body doesn't like to keep on the same thing, so usually we lifestyle modification usually going back to the usual thing. So continuous follow-up is very important to keep this weight maintenance. So you can see before coming to my nutrition field, I was like my weight was very high, around 80s, and after doing this successful nutritional training and for the last 9 years, I am able to maintain my weight as well without any anti-obesity drugs or any surgeries. So if you are motivated enough, that can be done, and it's but the motivation and the persistence is the most important thing. And there are new drugs available for obesity, like if the BMI is more than 30 or 27 with comorbidities. On top of lifestyle intervention, you can prescribe these drugs. Olistat is a pancreatic lipase inhibitor. It's good, but Sri Lankan context, if you are eating a lot of fat, then it's a good option to induce weight loss. And SGLT2 inhibitors are good if the patient is diabetic. Probably they can be useful. And GLP-1 receptor agonists are very much now coming into the field, and it will be available soon in near future, next year, probably next year. It's a good drug to reduce the weight and also the metabolic risk. If there is insulin resistance, we can of course use metformin. And pentoramine and topiramate combinations are FDA approved for weight loss and to suppress the appetite as well. Word on bariatric surgery. If the BMI is more than 40 or BMI more than 35 with obesity related complications, we can go for this bariatric surgery. It's very successful, and they are where they have two mechanisms. They restrict the food intake or they cause malabsorption. So they need to be followed up lifelong, because they can develop a lot of nutritional side effects. Laparoscopic sleeve gastrectomy is very popular these days, and it's a quite effective method as well. Mind you, there are some special situations where for the older adults, like BMI 23 to 25 is okay. We try to go for the like healthy dietary counseling. No, we don't try to induce weight loss for these sort of special categories, because they lose more muscle when we go for weight loss in older adults. And patients with liver disease, fatty liver, we should not induce rapid weight loss, because that will precipitate the NASH, and patient can go into liver failure. And pregnancy, always we should avoid weight loss. It need to be done pre-pregnant counseling time to induce the weight loss and the optimization of the glycemic control. Follow-up and monitoring is very important. As I mentioned earlier, 1 to 3 month interval repeating of the metabolic screen and the anthropometry will be beneficial. Don't do daily weight check or daily waist circumference measure. It's not accurate. Always like once in 2 weeks would be the ideal interval to check. And long-term maintenance with community support and the counseling is also very important. So what are the practical takeaways? Obesity is pandemic in alarming numbers, and lifestyle modifications is with modest energy deficit would be the way to go for the long-term weight loss. And consider medicines when appropriate, and surgery as well. Plan for long-term follow-up, because obesity is always like chronic and relapsing disease. These are my references. Thank you for your patient listening.
With this, right. So the nutrition care process. Now today we are going to talk mainly about the clinical nutrition. I hope Dr. Lasith has started with a very interesting topic. It's better that we started off with that, obesity. So with that, we will know why we are talking these topics. Why are we having a more training on this regard? So that is what I'm going to start with. Okay, thank you. Right, so why we do the nutrition care process? Yes, first we are mainly targeting the hospital nutrition. So as we all know, when a patient is admitted, they are either already malnourished or with the condition, the oral condition states that patient who's ill, the intake is low, and of course the energy expenditure is high with the infection and the underlying clinical condition. So they are in a negative energy balance. So this ultimately leads to malnutrition. So why we are worried about malnutrition? Because it is shown that the morbidity, wound healing, infectious risk, complications all increases with this malnutrition, and thereby the mortality, treatment cost, and the length of hospital stay increases, and also the quality of life reduces with the increased cost. So that is why this clinical nutrition come into play, where among the other medicine, if we don't have this basement with the nutrition basement to stabilize the patient, the overall outcome will not be very satisfactory. So when we talk about the clinical nutrition, we have some nutrition disorders and there are some nutrition related conditions. So I think most of the today's topics will cover and touch upon this to give you an overall idea. And also, we want to highlight your role as a MO in this care process. So, this nutrition care process is with few steps, starting off with the very important nutrition risk screening, assessment, diagnosis, nutrition therapy, monitoring and evaluation, and of course to continue with the documentation and follow-up. So why this screening? So this I see as a very important thing, because nutrition support team, as you all know, you have a nutrition medical nutrition team in your hospital, but we are a supportive team. Unless we get some referrals, we don't see the patient. So you see them on admission. So if you don't detect a patient had malnutrition, the patient will not get the benefit of proper nutrition management. So that is where this nutrition screening is important, and that is what we want the help from the other medical and the nursing team. So this is the first step of nutrition care process, which is used rapidly and simply to evaluate whether the patient is at risk or to become or at risk of becoming malnourished. This should be a simple and quick check, and it can be used either with a medical professional or other staff, and it should be at the first contact of the patient. So who should be screened, right? So who should be screened? All admitted patients must have a nutrition screen. Okay, so that is an important message that we want to give with this lecture series. Nutrition screening should be done to all admitted patients. Right. So how are we going to do this? That is what I'm trying to achieve this with these few minutes. So nutrition to screen, there are several methods, and the worldwide known practice is to use a screening tool. So there are different screening tools, but I will highlight one or two today. So the malnutrition universal screening tool, and the mini nutrition assessment, and the nutrition risk score, and the subjective global assessment. So the names are there. Let me go through one by one for a little while. So the malnutrition universal screening tool is a validated tool used in other countries, but this is something which is practical for us to do as well, and which is practicing in some stations. So there it is a 5-step small process. So without going through each of this, we'll just take a small example, a clinical history. So just imagine this history, okay? So you are getting a patient who is 35-year-old patient with a chronic wound for 3 months duration and with a reduced level of consciousness. So she has a background history of diabetes, CKD, anemia, and was bedridden since March 2025 after a ischemic stroke, and the left lower limb wound for 3 months. Okay, so when a brief dietary history, just looking at it, it shows that there was a minimal food intake for the past 2 weeks, and so the average calorie intake also mentioned, but when calculating the BMI is around 19.7, and the family is reporting that the patient's weight has reduced more than 5 kilos, which was a subjective figure given by them. So now you get this patient, right? So how are we going to screen this patient for the malnutrition universal screen tool? So this one, if we apply, so then this is again the tool. This is freely available on the web as well. So first step is to look at the BMI. So what was the BMI I told in the example? 19.5, isn't it? So that becomes 18 to 20. So the patient get a score of 1. Then the step 2, the unplanned weight loss, although it is ideally should be with the objective value, I use the subjective weight loss more than 5%. So 5 to 10 within the past 3 to 5 months. So that again gives 1 score. And then the last step 3 is the patient is acutely ill, and there has been likely to be no nutritional intake for more than 5 days. So both things are there in this history that I gave you. So these patients get a score of 2 there. So the step 4 is to add on this. So 2 plus 1 plus 1. So that gives a score of 4. So then you categorize. Okay. Now the score of 4 more than 2 is the patient is at high risk of malnutrition. where the plan should be to treat. Okay, so if the score is 0, you say the patient is low risk. You rescreen after once a week or twice a week, depending on the clinical situation. If it is 1, it is medium risk. Then you again repeat the screening. But now this is 2, so you have to plan the nutrition care for this patient. So this is one example where we expect you to practically use this tool. So another one is this. The malnutrition, the mini nutritional assessment short form. So the difference, if you go through, we have there is acute disease, or the psychological condition is included, then the dementia and depression is included. Why? This was designed for the older adults. So when you have a patient more than 65 years, since this tool is validated for more than 65-year-old, this gives a more accurate interpretation of the nutrition risk. So this becomes actually a screening plus an assessment tool, but the short form is used for a screening purposes. So again, just to make yourself not sleeping in the early morning, just another example. So this is a 75-year-old widow who has brought out for the outpatient department by her daughter, saying that her mother was withdrawn, low mood, and her food intake is reduced since their father's death 2 months ago. And again, a subjective weight loss is reported, but not exact values coming by them. And she has had an accidental fall during the same time period, where she had undergone a right hip fracture and the hip replacement, but no post-surgical complications. Now she was rehabilitated and able to mobilize slowly with a cane. BMI is 19.5. So since this is a 75-year-old patient admitting to your ward, we have decided to use the MNA, or the mini nutrition assessment short form. So the first one is about the intake. So we know that there was a reduction of the intake. So I give a score of 1, saying moderate loss of appetite. Then the weight loss during the past month, we are not sure about any value. So I give a score of 1, saying that we don't know. Then what about the mobility? Yes, with the cane she is able to mobile, but she is not going out alone. So I again gave a score of 1. So any psychological distress? Yes, she has. The husband was passed away, so yeah, obviously there was a psychological distress. So a score of 0. And then any neuropsychological problems, low mood, everything. So the severe dementia or depression. So since there is a component of depression, a score of 0. The BMI is 19, so 19.5. So again the score of 1. So ultimately when you add, so if you can't calculate the BMI for this elderly, you can use the calf circumference. All right. So the calf circumference is the most prominent contour in your calf, in the patient's calf, and you get the circumference. And if it is less than 31, you give the score of 0. If it is more than 31, you give a score of 1. Ultimately, when you add here, you know that this patient gets a score of 4. So 0 to 7 means the patient is malnourished. So the total score is 14. 0 to 7 becomes malnourished. 8 to 11 is at risk of malnutrition. And 12 to 14, it is the good nutritional status at the current examination. So this is a practical way of applying these two screening tools. I hope you got some idea of applying a screening tool to a patient when they get admitted. So this is another one gold standard one we are using, the subjective global assessment in the screening plus an assessment tool. So I'm not going to go through. This includes both history and examination. The similar way you can apply the history or the patient's condition into this and you get a score. But remember, this is a subjective assessment and ideally this should be practiced by a trained or a professional in the nutrition field. So the subjective global assessment is mainly not just a screening tool, is an assessment tool too. Okay, so I hope you got a clear idea about some screening knowledge. But if we don't have this tool, at least go by the body mass index, which I will be talking in a little while. At least if you identify a patient whose BMI is less or more, should be referred to a nutrition team. Then the second step, if you can recall, in the nutrition care process is the nutrition assessment. This is a more detailed. So when you identify a patient at risk of malnutrition, you refer to the nutrition team. They come and do a detailed nutrition assessment. So this needs a nutrition expert for specific evaluation. So easiness of remembering, we go by this ABCD method. So anthropometry, biochemical assessment, clinical, dietary assessment, and looking at the environmental factors. So for easiness of explaining, I will stick to this ABCD pattern, but as you all know, when you get a patient, you get the history examination, you do the investigation, so that process will go on, but for my easiness to explain, I will stick into this ABCD pattern. So the anthropometric measurements, what do you do? Yes, so the physical dimension and the composition of the body. So the height and the weight, like the basic assessments. BMI calculation, so I don't think for this audience I have to explain how to calculate that. Then the other circumferences, the weight circumference to assess the central adiposity, which is linked with the metabolic risk, the skin fold thickness, mid-upper arm circumference. So the skin fold thicknesses to estimate the body fat, you use the subscapula or the tricep skin fold thickness. So you get a fat percentage of that. And the mid-upper arm circumference, I'll show a diagram. We'll talk it at that place. Why am I talking in this forum? These simple things, because to get an interpretation of these values, accurate measurements are mandatory. ඔයලඩාගේ බර බලලා දෙන්න කියලා අපි සාමාන්‍යයෙන් we just give it to a attendant, isn't it? But remember, to come to a nutrition diagnosis, these values are very important. So as responsible team leaders, we have to make sure that the machine that we are using is well calibrated, and the technique that we are using, like make sure that your patient is not having any phones and everything in his pocket while he's measuring, especially the kids. The small, about 0.5 kilo difference of weight means a big difference. So it is very important that we get the accurate measurements, and also measuring the height properly. There is a method that you should measure in the height, because again, especially in kids, this 0.5 centimeter difference gives a huge difference in interpreting the nutrition status of the child. So touching 5 points, the head, the back of the chest, the buttocks, the calf, and the heel. So touching with the wall, and also the eyes on the Frankfurt line is a imaginary line drawn parallel to the floor across the tragus and the corner of the eye. So this plane should be parallel to your floor, and that is the position you have to keep the patient, and then measure the height. So the correct technique, it improves the accuracy. Then calculating the BMI. Here again, I have shown the criteria, the WHO criteria and an Asian criteria. So I hope our MOs are now well aware that this Asian criteria was developed because the non-communicable disease risk is higher among Asians, because we have a higher fat composition in our body. Internal fat is high. So that is why these lower cut-off points in the Asian countries. But at least if you go by the WHO criteria, if it is less than 18.5, or if it is more than at least 25 or 27 BMI, refer to the nutrition clinic for nutrition support. So this is what I meant by the mid-upper arm circumference. So that is the midpoint between the acromion process and the ulna process. You mark the midpoint with a non-dominant hand in a bent position. Then you mark the point, extend the arm, and get the circumference. So that gives the circumference, gives the muscle plus the fat. Mid-upper arm circumference gives that value. So there is a possibility of getting the mid-upper arm muscle circumference by some calculations. But this is important for us to monitor a bedridden patient or to estimate a BMI. We have the charts for that. So this measurement will be important in bedridden patients to monitor their clinical assessment of their nutritional status. So this again a picture of that. So that is the anthropometry, the baselines, even the waist circumference and all proper techniques are important, but I'm not going to go into detail since the time restrictions are there. So then the biochemical assessments. So to complete our clinical, before coming into the clinical, because I'm going in ABCD approach, so the biochemical means the analysis of the biological samples to assess the nutrient level. So it can be the serum proteins, hemoglobin, electrolytes, the lipid profiles, and the micronutrients, whichever is available with us. So all these are included. Why we are talking with these interpretations, we have to be cautious, especially with the serum protein and the albumin. So most of the referrals we get is due to, okay, this patient is having low albumin, please improve the nutrition status. But I have to highlight this albumin is a very crude marker as a single parameter for the nutrition status, because it has so many factors, the body fluid volume, the inflammatory status of the body, because albumin is a negative acute phase protein. So it can go down when the infection or inflammation is running inside the body. So it doesn't indicate, since the albumin is low by itself, it doesn't indicate of any nutritional problem directly, but this is important. The serum albumin reflects disease severity and is a good predictor of the outcome. Okay, so but purely considering only the albumin is not a good indicator for the nutritional status. So that is why this assessment includes many things, not just one parameter. So as medical officers, we'll try to get this into our heads. Giving just albumin is not going to correct the nutritional status of the patient. This is a very crude measurement, but important one, especially a pre-operatively. All right. So that is a brief from the biochemical. Then the clinical assessments, obviously, we do a nutrition-focused physical examination, including the anthropometry, to identify any obvious malnutrition or nutritional deficiencies. And also the history should include the diseases and everything in the detailed history, and examination is very important. As any of the house officers taking a detailed history, we have to make sure that all these things are taken, including a detailed dietary history, because eventually we have to give a diet plan for these patients. So you can't give whatever you feel. You have to consider the background clinical condition plus the patient's acceptance and the whether it's the vegetarian that we are talking about. So all these things we have to assess. And also assessing the environmental and socio-economic factors influencing the nutrition also we have to consider. It's not that we are prescribing some antibiotic and sending off. No, it's not that. Sometimes this patient goes on with this plan. So can the patient continue this? So all these, the living conditions, so socio-economic status, cultural practices, all these systems should be thought of. So we did the screening, we do the detailed assessment. With this, we come to the proper nutrition diagnosis. So the reason in the world we have got the GLIM diagnostic process, which is the Global Initiative for Malnutrition. So again, they have given a process by the screening and the two types, the phenotypic and the etiologic criteria. So if you can recall the history that I told, this lady, the 75-year-old lady, so this patient was having a low body mass index, and also the food intake was reduced, and there was a background inflammation going on. So one phenotypic and one etiologic criteria is given. So the patient is malnourished, but then we have to determine whether it's moderate malnutrition or severe malnutrition. So that depends on the percentage of the weight loss or the muscle mass. So roughly this patient becomes into mild to moderate malnutrition. So this is a basic way that we show you how we arrive at a diagnosis, but it is not just that. We go by the background clinical history as well. And then the next step, so the screening, assessment, you do come to nutrition diagnosis and the medical nutrition therapy, which my colleagues will talk to you about in different aspects of the nutrition disorder. So it depends. Even the screening tools can depend from disease to disease. Now the newer techniques are coming. Special screening tools are developed for disease specific type also. So those things will be discussed by my colleagues when it is necessary. And this is a broad idea how we do the medical nutrition therapy. So we take the background and we set a nutrition goal, and then what is the immediate goal and what is the long-term goal that we have to do. We have to calculate the nutrient, fluid and the other micronutrient requirements, and then the instructions for implementing this plan should be given, and the route of administration and the duration of therapy that the patient needs. Everything should come into this nutrition prescription. So you give the prescription, but make sure the team is following up. So our team comes and gives a plan and says that this patient needs to be reviewed in 2 days with this set of investigations. So that is again where we need your support a lot, because we prescribe and go, but we need your support to make sure that this therapy is going on with the relevant investigations. Okay, so our colleagues will highlight you the importance of this monitoring of certain nutrition emergencies as well. So without proper monitoring clinically and biochemically, we cannot give the maximum, and therefore that's why we need the medical officer support plus the nursing staff support in implementing this nutrition care plans. So with that, we have to arrange a proper follow-up. As your other medical patients arranging the clinic follow-up, these malnourished patients, to have a proper follow-up is needed to achieve a best outcome. So what I try to highlight today is malnutrition in hospitalized patients will deteriorate the overall patient outcome, and the screening is indicated for all admitted patients. Accurate anthropometric measurements are essential. Careful interpretation and biochemical parameters are necessary, and arriving at a proper nutrition diagnosis will enable the best management plan for the patient, and the medical nutrition therapy with monitoring and follow-up should be done with the proper documentation. So thank you very much to all of you for your kind attention.
So let's talk about enteral nutrition. What is enteral nutrition? By definition, any method of artificial feeding that uses the gastrointestinal tract to deliver part or all of caloric requirements. Right? So, what are the indications for enteral nutrition? So, if you anticipate inadequate oral intake for more than 7 days with present or imminent malnutrition, that is the indication for enteral nutrition. Right? What do you mean by inadequate oral intake? If you are unable to eat for more than 7 days or less than 60% of recommended intake for more than 10 days, that is considered as inadequate oral intake. Right? So what are the benefits of enteral feeding? It maintains the GI tract functions and integrity, and it stimulates GI contractility, and it supports gut and mucosal associated lymphoid tissues. It preserves gut microbiota and prevents parenteral nutrition associated infective and metabolic morbidities. All of you know there are a lot of complications with parenteral nutrition, especially infectious and infective and metabolic complications. So when compared with parenteral nutrition, enteral nutrition is beneficial if it is possible. So if the gut works, use it. Let's talk about gut barrier. Now, under these benefits of enteral feeding, I mentioned the integrity of the GI tract. So with regards to the integrity of the GI tract, this gut barrier is an important factor. So gut microbiota, intestinal mucus and epithelial cells are considered as physical barrier, and gut associated lymphoid tissue or GALT is called functional barrier. So this gut barrier is very important for the integrity of the GI tract. So what are the contraindications to enteral nutrition? Severe functional disturbances of the bowel, gastrointestinal obstruction, and metabolic instability and circulatory instability. So these are the contraindications for enteral nutrition, and I have given enough examples for each contraindication. Right? Then let's talk about complications of enteral nutrition. You can divide into mechanical, infectious, and metabolic. So what are the mechanical complications? Tube obstruction, primary malposition, perforation of the intestinal tract, secondary displacement, knotting of the tube, accidental tube removal, breakage and leakage, and bleeding from insertion site, erosion, ulceration, and necrosis. So, an intestinal obstruction also complication of, those are mechanical complications. Then what are the infectious complications? Infection of the tube insertion site, aspiration pneumonia, nasopharyngeal and ear infections, peritonitis, infective diarrhea. Moving into metabolic complications, so electrolyte disturbances, hyper and hypoglycemia, vitamin and trace element deficiency. So these are metabolic complications, and sometimes refeeding syndrome also can occur. So what to give through this enteral route? So you can divide these feeds into many categories, right? So polymeric, oligomeric, mainly polymeric and oligomeric. Polymeric means feed with large molecules. Oligomeric means partially digested or fully digested forms. So disease-specific formula, again, some modification of this polymeric formula, and other formula also modifications. So this commonly used kitchen feeds or blenderized feeds also kind of polymeric if you prepare it properly. Right now, what we use in the hospital setup, instead, other than this kitchen feed, we use commercial products as well. So I will describe one by one. So commercial products, again, you can categorize as standard or high protein or high energy, right? So standard polymeric formula, usually energy density should be 0.9 to 1.2 kilocal per ml, and out of that, out of total energy, 15 to 20% should provide from protein. In high protein formula, more than 20% of the energy should come from protein. And to consider as a high energy formula, energy density should be more than 1.2 kilocal per ml. So oligomeric means partially digested. Usually in semi-elemental, protein is there as peptides. I will describe in my next few slides. In elemental formula, protein is there as amino acids. So that is the difference of polymeric, semi-elemental and elemental. For the disease purposes, there are commercially prepared ones with certain modifications of the polymeric formula. So to get an idea, I have shown here few commercially available polymeric formula. Some of these products are familiar to you all. I have no conflicts of interest. I have displayed all the available products in Sri Lankan market, right? So all these are polymeric formula. And these are oligomeric formula available. Only 3 products are available in the Sri Lankan market. Partially digested the formula. Here protein is there as peptide, and lipids is there mainly as medium chain triglyceride, MCT, and carbohydrate source is most of the time maltodextrin. I will compare polymeric and oligomeric in my future slides. And this is energy dense formula. Energy density is more than one. Here it's about 1.5 kilocal per ml. But certain polymeric formula also can be prepared in the energy dense form. not all, but in some products they have recommended preparation like that. So I showed you some polymeric and oligomeric. Then this is energy dense formula, and these are disease specific formula. So these are the available disease specific diabetic formula. What is the main feature of diabetic formula? It contains more fiber when compared with standard polymeric formula, and at the same time it doesn't contain sucrose, but most of other therapeutic formula contain sucrose. So that is the difference. And another kind is there, immune modulating formula. It contains immunonutrient. What are the immunonutrients? Glutamine, arginine, and omega-3 and nucleotides. So these three products contain immunonutrients. And these are renal formulae. So all renal formulae available in the market are here, except one product. I have missed one product. No, all are here, right? So the main feature is electrolyte content is low. Sodium, potassium, and phosphate is usually low in these renal formulae. And in later stage of renal disease, we restrict protein if patient is not on dialysis. So that's why protein content is low in these renal formulae. But if you go for dialysis, protein content is high. These are dialysis formula. Protein content is high when compared with these renal formulae, and when even higher than polymeric formulae. So this is again respiratory formula. Usually fat content is higher when compared with polymeric formula. So that is for reduce the respiratory quotient. And hepatic formulae, the main modification is branch chain amino acid is there, and if there is fluid restriction, energy density also high. And I couldn't mention under renal formula also, usually energy density is high because most of the time fluid restrictions are there in renal patients and liver patients. So sometimes in pulmonary diseases also. So usually energy density is high in renal and sometimes in hepatic formula also. And these are not polymeric or oligomeric. These are actually isolated nutrition products. This contains only protein. So there are two kinds of protein, whey protein and casein. So these are the available products with whey protein, right? Only 3 products in the market, medically recommended. I know there are a lot of whey protein products in your gym or those centers, but those are not medically recommended. These are the only 3 products which are medically recommended in the hospital setup. And casein protein formula, this is the product available in the hospital setup. And carbohydrate loading products. So these are used for carbohydrate loading. If you follow ERA's guidelines, usually it is recommended to give a carbohydrate solution at 6 hours before surgery and 2 hours before surgery. For that purpose, we can use this carb CH. Previously, there was a product called preload in the market. Now it's not available in the market. So this is the only available product, right? If you go to specifications of oral nutrition supplements, low energy means energy density is less than 1 kilocal, and we call the normocaloric if the energy density is 1 to 1.2. If it's more than 1.2, we call it high energy formula. And if protein provides more than 20% of the total energy requirement, that is called high protein formula. If fat provide more than 40% of the total energy, that is called high fat formula. If there are significant amount of MCT, that is called MCT rich formula. And if MUFA provide more than 20% of total energy, that is called high MUFA formula. And if that product contains glutamine, arginine, or omega-3 fatty acids, that is called immune modulating formula. This is very important. Enteral formula should not contain lactose, gluten, cholesterol, or purines. Right? Even though you call it milk, kiri කියලා කිව්වට පිටි කියලා කිව්වට කිරිත් නෑ පිටිත් නෑ okay. හරි? lactose උත් නෑ palm පිටිවල තියෙන gluten උත් නෑ. Right? ඒ දෙක නැති වෙන්න ඕන. So these are special therapeutic formula. Right? kiri පිටි නෙමෙයි. So in typical standard formula, usually, as I previously mentioned, 15 to 20% of energy should come from protein, and usually 30% of energy should come from lipids, mostly LCT, and 50 to 55% of energy should come from carbohydrate. Energy density is usually 1 kilocal per ml, and fiber should be there, but there are preparations without fiber as well. If you compare polymeric and oligomeric formula, usually carbohydrate source is polysaccharides or maltodextrins in polymeric, but in oligomeric, carbohydrate source is maltodextrins. Molecular weight is high in polymeric, in oligomeric it's low. Protein source is protein in polymeric and peptides in oligomeric. Fat source is mainly LCT in polymeric formula, and it's mainly MCT in oligomeric formula. So what are the indications for oligomeric formula? In what kind of situations where absorption and digestion is reduced, you can use this partially digested formula, right? For example, in ICU patients and those with acute pancreatitis, patients on jejunal feeds, and selected patients with short bowel syndrome, and selected patients with Crohn's disease. So previously also I mentioned regarding this immunonutrient and indicate what are the indications for immunonutrient usage: major head and neck surgery, major upper abdominal and cancer surgery, after severe trauma, mild sepsis, and ARDS. So how to select the enteral nutrition device, whether you are going to use a nasal tube or PEG tube. So that depends on the underlying disease and clinical prognosis and anticipated duration of feeding and patency and motility of the gut and risk of aspiration and experience and skills of the staff. So here are the routes of enteral access for artificial feeding: NG, NJ, PEG, PEG-J, or fine needle catheter to the jejunum. So if you are going to keep NJ or NJ more than 4 to 6 weeks, then you have to consider PEG or PEG. So that is the recommendation, right? What are the issues related to NG tubes? Malposition, potential reflux esophagitis, and potential psychological burden. So complications of PEG, all of you know: bleeding, tube site infection, intraperitoneal leakage, perforation of small or large bowel. So buried bumper syndrome, I am not going to describe because I have only limited time here. And there are ways of prevention of PEG complications, right? That is also I'm not going to describe because of lack of time. And fine needle catheter jejunostomy, also one method of feeding. And there are various ways of feeding, maybe bolus or continuous feeding. If you provide 200 to 300, 6 to 8 hourly, that is called bolus feeding. And continuous feeding, you can use using a feeding bag or feeding pump, especially in situations where feeding intolerance or high aspiration risk. If you notice high gastric residual volume or vomiting, then you have to consider prokinetic agents like metoclopramide, erythromycin. Erythromycin is used there not as an antibiotic, as a prokinetic agent. It's a BD dose, okay? Then summary is the goal of enteral nutrition is the prevention and treatment of malnutrition to improve the outcome. And if the gut works, use it as much as possible. Route of enteral feeding should be selected appropriately according to the underlying clinical situation. and correct selection of the type of formula and following the nutrition prescription accordingly is important, and careful monitoring to prevent and early detection of complications is important. Thank you. Today I am going to complete the second sessions of nutrition method, parental nutrition. It is very important concept after the parental nutrition. Let's see. Okay, what is definition of parental nutrition? Parental nutrition is an intravenous administration of nutrition, protein, carbohydrate, fat, electrolyte, and vitamins, including minerals, for a patients who cannot eat or absorb enough food through the tube feeding formula or enteral mouth. We are using the parenteral access administration of nutrient purely by veins. Here mainly we give sterile liquid directly into the bloodstream. That is the fundamental of this. Okay, general rule, as Dr. Nalinda clearly mentioned, the enteral route is a preferred route. It is a more physiological, less demanding and less risky and less expensive. Therefore, if it is indication, we have to go for the parenteral nutrition. Okay, what are the indications of parenteral nutrition? When it is not available, not possible to administer enteral nutrition because of gut is not functioning due to perforation, obstruction, or maybe the palatic ileus, inadequate absorptive or propulsive capacity, sometimes due to the severe ulcerative severe Crohn's disease, you have to go for inadequate absorptive capacity. Therefore, you have to go for the parenteral nutrition. When the gut is not accessible, like anatomical reasons, sometimes you can't access the gut due to the carcinoma or the obstruction of the GI tract. When the tube feeding is not safe, ischemic bowel, and unlikely to be effective in patient with intractable vomiting, you can't use the enteral access. Okay, this is more systematic way of indication of parenteral nutrition. If oral nutrition is possible, please go for the oral nutrition. If it is impossible, you have to go for the enteral nutrition. Start enteral nutrition according to the availability. And enteral nutrition, more than 60% of energy and protein needs in next 3 to 5 days. You have to optimize the enteral nutrition. If it is impossible, or you can't go for beyond that, you have to start with parenteral nutrition as a supplemental parenteral nutrition to supplement the energy gap. Then if it is still low, then you have to go for the parenteral nutrition. Yeah, as a summarized version, it is we are not using parenteral nutrition purely depend on the disease state, but the prioritizing or initiation parenteral nutrition purely depend on the nutrition screening and assessment. And parenteral nutrition should be given if enteral nutrition is impossible during next 3 to 7 days, or if it is impossible enteral nutrition, patient is malnourished, you have to go for the parenteral nutrition. Okay, what are the contraindications of parenteral nutrition? GI tract is fully functional, you can't use the parenteral nutrition. It's a fundamental of the nutrition, and hypersensitive to any kind of component for the parenteral nutrition, such as egg albumin. Prognosis does not improve the parenteral nutrition. You can't use a terminally low palliative care patient. If patient is in terminally, you can't use parenteral nutrition. Patient is unstable, acute shock, severe metabolic acidosis. You can't use. You have to stabilize the patient before the parenteral nutrition. Any kind of nutrition, first stabilize the patient. Inability to maintain, inability to obtain the proper venous access, or risk exceed the benefit, you can't use the parenteral nutrition. Okay, there are two types of parenteral nutrition access: central venous access and peripheral venous access. You can see we can use central venous access, usually more than up to 2000 milliosmol per liter osmolality, and blood flow may be more than 1000 milliliter per minute, that kind of situation. If you use peripheral cannula, its blood flow may be less than 100 milliliter per minute, and osmolality should be less than 800 millismoles. Okay, these are some sites of the central venous. You can use jugular veins, both external and internal jugular veins, subclavians, peripherally inserted central catheters, but catheters tips should be at atriocaval junction. That is a fundamental here. Okay, this is a parenteral nutrition multi-step process. You have to assess the body composition, nutritional assessment should be done, laboratory test, dietary history, refeeding risk, you have to assess first. Then you have to go for the clinical data such as inflammatory activities, comorbidities, and other IV access, the availability of the level of the fluid intake, and you have to go for the parenteral nutrition prescription. Then prescription, you have to go for the parenteral nutrition, whether you are going for central parenteral or peripheral parenteral. Here also mainly we are going for the peripheral parenteral nutrition or central parenteral nutrition with the commercially available multi-chamber bag or the hospital prepared one. Or then you have to go for the monitoring aspect. Okay, how we give in parenteral nutrition in Sri Lanka? Mainly peripheral lines, as you know, and central venous line. Okay, there are three types of central venous access devices. Tunnel catheter, usually you use for the long-term parenteral nutrition process, and non-tunnel catheter, as well as the peripherally inserted catheter starting from brachial area. You have to insert it through the subclavian vein into the atriocaval junction. Okay, modes of delivery, as we discussed earlier, central parenteral nutrition and peripheral parenteral nutrition. Central parenteral nutrition administered to central line, osmolality solution more than 900 or maybe 850, like can be given for more than 2 weeks. That is a fundamental of putting the central line, provide complete nutrition supporting central venous access, and central parenteral nutrition. We can give complete nutrition access, but peripherally administered to the peripheral line, osmolality may be less than 900. Indication for shorter duration, usually less than 2 weeks, generally intended as a supplement to the oral loaf and enteral nutrition, but you can use as a pure source of nutrition, but it is not a complete version of the parenteral nutrition. Okay, there are several system of parenteral nutrition delivery system. You can go for multi-bottle system, but it is not a ready-to-use variety. You have to reconstitute it. And bottle in Sri Lanka, we are also having the several bottle preparations. You can see the first one bottle system, two bottle system, and here in Sri Lanka you have seen common. There are 2-3 preparations all in one admixture. It is plus or minus electrolyte as well as vitamins. All in one PN administered, safe, daily requirement, properly compounded, and document stability also there. Efficient also, because less handling and very easily and the time saving, convenient, single container and single line you can use. This is for the multi bottle system. This is not available in Sri Lanka anywhere in Sri Lanka, but most of the other part of the world they use this is used as a customized individual customized parenteral nutrition. This should be have a laminar flow and laminar flow with a very good lab facilities. This is a multi-bottle system. There are several varieties: protein, electrolyte, carbohydrate, and all. Okay, all in one admission is amino acids usually generate 4 kilocalorie, glucose usually 3.4 kilocalorie generating, lipid is usually 9 kilocalorie, energy usually administered into the bottle up to the 20 to 25 kilocalorie per kg per day. Like amino acids maybe 0.8 to 1.5 grams vary. Lipid also 0.5 gram per kg per day to 1 gram per kg per day included into the one bag. Glucose 3 to 6 gram per kg per day. Water also 30 to 40, like electrolyte and vitamins also there. In commercially available multi-chamber bag, usually having lipid, glucose, amino acid, and several minerals. This is very the famous form of the parenteral nutrition bag available in Sri Lanka. But keep in mind, these are not complete form of nutrition. Okay, compound versus ready-to-use MCB, that multi-chamber bag, long shelf life, large range of multi-chamber bag, hospital with no aseptic facilities available like in Sri Lanka or anywhere in Sri Lanka. After preparing multi-chamber bag, you have to, when you constitute it, you have to use within 24 hours. Small therapeutic index, one bag does not fill all, need adjustment as well. Compound, that it is tailor-made, individualized. Therefore, you can use as an individual need. Patient is rapidly changing requirement. You can use like children and ICU. Unfortunately, at the moment in Sri Lanka, it's not available. Drugs and all-in-one bag. All-in-one bag administered are not good vehicles for drug. You can't put many type of drugs into the bag, but you some form of preparations. Only insulin you can accept it sometimes into the all-in-one bag. Okay, all-in-one bag administer are the preferred form of parenteral nutrition in this part of the world, especially the pharmacological studies support using standard multi-chamber bag system, need for compounding, tailor-made PN and ready-to-use preparations for commercial MC bag. All-in-one PN administer have high potential for interaction, including potential harmful and stability risk there. And you have to use very good practice of preparations, and very suitable for the facilities are not available ready, but it is not suitable for drug delivery as a drug delivery vehicles. Okay, what are the risks associated with parenteral nutrition? There are several risks. Infective risk due to the poor aseptic compounding or administration, micronutrient addition at the ward setting. There are metabolic complications, PN associated hyperglycemia, refeeding syndrome, bone loss. There are several things. Mechanical catheter occlusions, compounding administrators, incompatibilities, and sometimes air embolism as a cause of mechanical complications, toxic complications, fat emulsion deterioration, some fat oxidative stress, lipid peroxidations, and drug errors also. They are ready to use preparations with several the compounding errors which can be avoidable, and economical errors as well, and other errors as well, handling, patient's care, quality of life, administrative errors, all are there as a complication of parenteral nutrition compared to enteral nutrition. Okay, why do we talk about the infection mainly? There are several complications, but infection is the most common complications we face during the parenteral nutrition. Catheter-related bloodstream infection or Krebs are the one of the most frequent and lethal complications, especially central line. In incidence of Krebs, the central line is 64 times higher than the peripheral line. Therefore, if you use peripheral preparation of parenteral bag, you have to go for the peripheral catheter instead of the central line. Administration of parenteral nutrition increases the risk of the Krebs. Prevention of complication, optimal PN preparations, impact line entry sites, daily inspect, proper line care. Knowledge is very important. That is why we are going for the more and more training sessions here. Okay, just I am going what are the intestinal failure and the home parenteral nutrition, because there are home parenteral nutrition services in worldwide, but in Sri Lanka at the moment not available. There are type 1 intestinal failure, very short term. We are not going for the not going to supply anything during that period, but type 2 intestinal failure, you are going for giving parenteral nutrition in this kind of situation. Usually in the hospital after surgery, maybe weeks duration, you have to give for parenteral nutrition in this kind of situation. Third type intestinal failure is a chronic long-term intestinal failure. Therefore, you have to supply all the nutrient by the parenteral route. We call home parenteral nutrition services. It's a form of long-term parenteral nutrition for intestinal failure. Premixture bags are used. Cost is very high compared to the EN. Lot of training should be done. The survival benefit to the patient, staff training is essential in here. Okay, what are the monitoring of parenteral nutrition? You have to go for the initial part, vital signs, daily examination of edema, dehydration, wound healing, catheter site infection, maintain fluid balance chart, temperature chart, maintain weight and mid-palm circumferences chart. What are the monitoring of, you have to do initial monitoring, daily monitoring and weekly monitoring. Electrolyte you have to use for monitoring as a monitoring purpose daily. And some electrolyte like potassium, phosphate, magnesium, the initial monitoring maybe to 3-4 days, then the finally weekly monitoring is enough. Glucose should be daily monitoring, and liver function should be weekly monitoring, because liver function dearrangement can be happen with the parenteral nutrition, and triglyceride full blood count also should be there. Okay, what are the benefits of parenteral nutrition? The first thing again, oral or enteral nutrition is the first choice of the patient when the gut is not well. Parenteral nutrition is the only nutrients supplied to the body. When the gut fails, parenteral nutrition reduces the risk of interruption to the treatment, including surgery and the very significant treatment process like chemotherapy or anything. Improve the treatment related side effects, including vomiting, nausea, improvement of nutrition status, including weight, BMI, BIA, and there are several other markers like face angle values of the BIA and albumin. Improve the quality of life, including physical, social, and functional, patient satisfaction and perception of the well-being, and improvement of the malnutrition at the finally. Okay, thank you very much for this brief presentation. End of the lecture, we are going for the not the finally question and answer. Okay, thank you very much.
My topic is critical care nutrition. So, first of all, we'll see why critical care nutrition is so important. Evidence shows critical care ill patients, when compared with the ward patients, it shows more than double they are at risk of malnutrition. And when considered about the ward patients, the nutritional risk is associated with longer hospital stay. But in critical ill patients, this process occurs irrespective of the adequacy of the nutritional support, and also there is a dramatic depletion of lean body mass, especially the skeletal muscle mass. And in ward patients, weight loss is typically due to immobility, inadequate nutritional intake, or the poor tissue utilization of the nutrients. So, what are the goals of medical nutrition therapy in critically ill patients? First, it is very important to early identification of these patients and do the timely interventions to prevent and treat the malnutrition. And also, one other goal is decrease the catabolic response of this patient to prevent oxidative cellular damage and preserving the lean body mass of ICU patients. And that anyway accelerate the recovery from disease and shorten the convalescence period. These are the benefits of feeding critically ill patients. It is important to maintain the immune response of these patients, and especially the surgical patients, improve the wound healing and also reduce complications, like example pneumonia, and reduce the length of ICU stay and also the period of ventilation. And anyway, finally, it reduced the morbidity and mortality of these critically ill patients. So this diagram shows the metabolic stages of critical illness. You can see it can divide it into two phases. First, the first week is called the acute phase, and after that, that is post-acute phase. Acute phase also we can divide it again into two phases, early and late phase. During the first 2 to 3 days, and flow phase, and the second acute phase is late acute phase. So during that acute phase, there are a lot of disturbances of the homeostasis, and after first week, that is post acute phase, it is convalescence and also the rehabilitation that depend on the clinical condition of the patient. So what are the metabolic responses of critical illness? So actually it is the adaptive responses occur in critical illness in order to enhance the chance of survival of these patients. So cell metabolism altered to prioritize the delivery of energy and essential metabolic substances to the vital organs due to several stressors. So it is a complex condition involving multiple organ systems, neuroendocrine, inflammatory, and also different hormones released from GI tract, also from the adipose tissues. So there are a lot of acute mediators involved in this critical illness. Primarily, there is a stimulation of sympathetic nervous system, release several hormones, and also activation of the hypothalamic pituitary axis. Later on, there are a lot of inflammatory immune responses occurs, release of the various cytokines, inflammatory mediators, antibodies, especially the interleukin 1 and interleukin 6. They all contribute to the fat and protein breakdown, and there is uncontrolled oxidative stress leading to mitochondrial damage in these critically ill patients. So, what are the steps of medical nutrition therapy in critically ill patients? As discussed early in the first lecture, we have to start with the nutrition screening, followed by nutrition assessment, and we'll have to come to a nutritional diagnosis. That it is very important to calculate the macro and micronutrient requirements, selection of the route of the nutrient administration of these patients, and delivering of the target nutrients. And also these ICU patients, there are a lot of complications you can see. So complication management also important. And finally, we'll have to monitor these patients, and evaluation and readjustment of our nutrition care plan is important. So I'm not going to discuss detail about the nutritional screening, but it is in the guidelines. The recent evidence shows every critically ill patient who is staying for more than 48 hours in the ICU should be considered as at risk of malnutrition. At the moment, there is no validated screening tool for the ICU patients, but we are using several screening tools, especially the NRS 2002 screening tool, MUST screening tool, and NutriScope. Those are the commonly used screening tools in ICU patients. So this is the European Society of Parenteral and Enteral Nutrition Society. They are updated guidelines for the critically ill patients published in 2023. According to that, medical nutrition therapy shall be considered for all patients staying in the ICU, mainly for more than 48 hours, as they are considered as at risk of malnutrition. And also negative energy and protein balances are commonly observed in these critically ill patients associated with increased mortality and morbidity. When considered about the nutritional assessment, malnutrition in critical care can occur irrespective of the BMI. That not depend on the BMI, even obese patients can have malnutrition. So the nutritional assessment should follow ABCD approach as discussed early. And when consider about when we calculate the nutritional requirements, we usually take the actual body weight of these patients. However, obese patients, we are using the adjusted body weight for calculations. So now we'll see what are the energy requirements of these patients. Actually, actually, when calculating the energy requirement, indirect calorimetry is the gold standard way of measuring resting energy expenditure in ventilated patients. But it is actually not available in our country and very expensive. So in the absence of the indirect calorimetry, for the calculation of resting energy expenditure, we can use the volume of carbon dioxide and intake of the oxygen volume through the pulmonary artery that can be used. However, most of the time we use the simple weight-based equations that is roughly about 20 to 25 kilocal per kilogram body weight for the day, and also that changed with the clinical situation and the nutritional status. So other important thing is, in the first week, we are not going to give all the calculated energy requirement, because during the acute phase, we are going to provide about 70% of their requirement progressively, depending on the tolerance. So when consider about the protein requirement, it is usual protein requirement is about 1.3 grams per kilogram per day. That should be delivered progressively. However, that also changed with the clinical situation. For example, when we are consider about the burn patient in the ICU, if the patient is having more than 20% of the burn injury, we have to give roughly about 2 grams per kg per day. So that depends on the patient's clinical situation. Another important thing is physical activity, especially the physiotherapy, may improve the beneficial effects of nutritional therapy. So it is also very important. Now we consider what is the route and timing of nutritional support. According to the recommended guidelines, oral diet preferred over enteral or parenteral nutrition who are able to eat. If the oral intake is not possible, we have to consider early enteral nutrition, that is within first 48 hours should be initiated rather than delaying the enteral nutrition if the patient is unable to take orally. So patients not tolerate full dose of enteral nutrition during the first week. The safety and benefits of initiating parenteral nutrition should be weighed on case-by-case basis. That is very important. So this diagram shows what is enteral nutrition, as my colleague also described it earlier. So definition, I think you are familiar with it now. So if the patient's gut working, we have to use the gut. So absence of the gut feeding, that may represent important trigger for systemic infections. So if we are, these are the consequences of starvation on the gastrointestinal tract. So that is why it is important to feed the patient as early as possible. So increased permeability to the macromolecules and microorganisms, especially the bacteria, fungi, there is a possibility of increased adherence of bacteria to the enterocytes and overgrowth of these pathogens. So ultimately, atrophy of the Peyer's patches can happen, that will lead to decreased production of the immunoglobulins. So that is why it is important to feed the patient early. These are the indications of early enteral nutrition feeding. You can see there is a list of indications: traumatic brain injury, spinal cord injury, stroke patients, severe acute pancreatitis, and also after GI, gastrointestinal and abdominal aortic surgery. So those are the main indications for early initiation. And before starting parenteral nutrition, there is a checklist to we have to consider. So we all know there could be significant gastrointestinal dysfunction, that is intolerance. So gastric residual volume we can measure in the first 2 days. If it is more than 500 ml in 6-hour period, we have to delay the starting of enteral nutrition. And also there is a possibility of developing IBS. So when these conditions occur, we have to administer the enteral nutrition very slowly, about 20 milliliters per hour. And we have to monitor the gastric residual volume. Another important thing is positioning of the feeding tubes are important. And also the preferred types of feeding tubes are silicone and polyurethane. And also a patient position will have to keep the head of the bed elevation more than 30% degree if possible. And formula type, as discussed by my colleague, there are a lot of types of formula, but anyway, we usually start with the polymeric type of feeding. And also initial settings, it's better if we can start with continuous type of feeding, but we need pump and bags. But at the moment, actually, we don't have. But other countries, they start with the continuous type of feeding. These are the other indications for delayed enteral nutrition. If we can't start within 48 hours, even we can delay these conditions like uncontrolled shock or hemodynamically patient is unstable, active upper GI bleeding, overt bowel ischemia, high output intestinal fistula. Like these conditions, actually, we can still delay the feeding of these patients enterally. So parenteral nutrition should not be started until all reasonable strategies to improve the enteral nutrition tolerance have been attempted. So in case of contraindications, as discussed by my colleague, we have to, if the patient is unable to start on oral or enteral, PN should be implemented within 3 to 7 days. These are some of the indications for parenteral nutrition. So how we are going to monitoring this medical nutrition therapy in critically ill patients. This diagram shows we can divide it into 2 areas. Monitor for the tolerance, overfeeding and underfeeding. And other important thing is monitoring for the refeeding. I'm not going to discuss here, but monitoring for the tolerance, as discussed earlier, we can, the first line prokinetic therapy is intravenous erythromycin, or even we can combine with intravenous metoclopramide. Overfeeding and underfeeding, how we recognized, we have to monitor the blood glucose levels every 4 hours during the first 2 days. And if the blood glucose levels exceeds more than 10 millimoles per liter, we have to administer insulin. Next, we talk about the monitoring for the refeeding. We'll have to monitor the electrolytes, especially potassium, magnesium, phosphate, during the first week at least once daily. And if they are low, we have to replace them IV. Unfortunately, actually, we don't have intravenous phosphate in our country. Now we'll discuss briefly about the refeeding syndrome. Refeeding syndrome that describes clinical and biochemical complications that may result from reinstitution of nutrition in severely malnourished or starved patient from any route. It can be oral, enteral, or even parenteral. This refeeding syndrome is a life-threatening condition. There is a lot of complications involving cardiac, respiratory, and there is neurological complications. So this shows the pathophysiology of refeeding syndrome. You can see during starved phase of the patients, there is a reduced amount of insulin in the bloodstream and high levels of glucagon. So that leads to increased glucogenolysis, gluconeogenesis, and increased protein catabolism. And there is low levels of vitamins and minerals. When we start feeding these patients, especially the carbohydrate as the main source of energy, insulin secretion increases. That leads to increased protein synthesis, increased glucose uptake, and more thiamine is uses. And there is intravascular shift of phosphate, magnesium and potassium, and there is possibility of sodium retention that leads to increased extracellular volume. So all those leads to reduced levels of phosphate, magnesium, potassium, and thiamine deficiency, and salt and water retention that leads to various complications as mentioned earlier, that is called refeeding syndrome. So how we assess the risk of the patient to develop refeeding syndrome? We can divide these risk into various factors, various categories. There is minor risk factors, major risk factors, and very high risk factors that depend on the cutoff of various BMI values, and weight loss also we are considering very little or the intake during last 5 days or last 10 days. So all those things consider in the as risk factors, and we can assess whether the patient is at minor risk, high risk, or very high risk. Depending on that, our management changed. So it is important to do the fluid management, fluid restriction if the patient is having high risk of refeeding syndrome. Sodium restriction also very important, and energy advance need to do slowly. If the patient is at very high risk, we start with very low amount of kilocalorie per kg per day. And also at the same time, while monitoring, electrolyte replacement also very important, and thiamine will have to give adequate thiamine for the carbohydrate metabolism, and provision of micronutrients also very important. And finally, these are the take-home messages. Critical care illness leads to highly catabolic state with significant muscle wasting. So critical ill patients have modified energy and specific nutrient needs. Administration of appropriate amount of nutrients in order or enteral route is preferred over parenteral nutrition. Both insufficient and excessive amounts of energy is detrimental, and also optimal provision of macro and micronutrients is mandatory throughout ICU stay to promote the best possible outcome. And also monitoring of nutrition support is as important as the initial prescription. So thank you very much. Thank you very much.